Good afternoon, everyone. My name is Krit Na Nongkhai, and I'm from Khon Kaen Hospital. Today, I'm here to present our study, the progression-free survival of advanced stage epithelial ovarian, fallopian tube, primary peritoneal cancer between primary neoadjuvant chemotherapies versus primary debulking surgeries. So let's start with our introductions. Ovarian cancer ranked as the seventh deadliest cancer affect women worldwide. About two-thirds of epithelial ovarian cancer are in advanced stage, which is stage 3 and 4, and often treated with the cytoreductive surgery. There are two main options for the cytoreductive surgeries. The first one is the primary debulking surgeries, which is the PDS, followed by chemotherapy. Another option is the neoadjuvant chemotherapies, or the NECT, before the interval debulking surgeries. Most patients experience relapse of the disease within 5 years after the initial treatment, and only 20 to 25% achieving the long-term survival. Previous study indicate that neoadjuvant chemotherapy is not inferior to the PDS in the term of survival outcome. However, progression-free survival with the carboplatin remain unexplored. So our objective is to compare progression-free survival in advanced stage epithelial ovarian, fallopian tube, and primary peritoneal cancer patients receiving NECT versus the PDS. So we conduct the retrospective cohort study using the medical data from Khon Kaen hospitals. Our patient includes stage 3 and 4 epithelial ovarian, fallopian tube, or primary peritoneal cancer between January 2010 and October 2021 using the FICO staging 2014 with complete data. And we exclude unknown surgical procedures, unknown postoperative procedure, and unknown follow-up times. Our primary outcome is the progression-free survival, defined as the time from the initial treatment to the disease progression or death. Secondary outcome include overall survival, surgical and chemotherapy-related complications, hospital length of stay, and the optimal number of chemotherapy cycles. We use the SPSS statistical software version 28 for the statistical analysis. And we also use the Kaplan-Meier method and the log-rank test to compare the progression-free survival and overall survival between the women who underwent NECT and the PDS. As you can see from the figure 1, among 89 patients, 44 had neoadjuvant chemotherapies and 45 underwent the primary debulking surgeries. The outcome, median progression-free survival was slightly longer in the PDS group, which is 18.6 months, compared to the neoadjuvant chemotherapy group, which is 15.7 months. The PDS patients had a median overall survival more than the NECT group, but is not statistically significant. The PDS has longer operative times, higher blood loss, and more frequent blood transfusion than the NECT groups. Both groups experience similar side effects of their chemotherapy adverse events, include anemia and neuropathies. The result was different from those previous randomized trials, which showed similar progression-free survival in both groups. However, patients in the NECT groups show extensive stage of disease in those studies. There was no difference in operative time, intraoperatives, postoperative complications, but the incidence of hematologic adverse event was trend higher in the NECT groups compared to the PDS group, which is anemia and thrombocytopenia. This suggests a potential association between the number of chemotherapy cycles and the likelihood of the complications, as you can see from the figure 2, the Kaplan-Meier curve. So our study conclusion is the primary debulking surgery groups had significant longer progression-free survivals than the neoadjuvant chemotherapy group. However, overall survival time was not statistically significant. Thank you for your attention.
Surely this presentation inspired us all. Any comments or questions?
I wonder how did you identify the baseline characteristic between these two groups among the next group and PSD group? Are they similar or different in which aspect?
So they are the same. Uh, we using the fecal staging, and some of the patient characteristic is the same, just like the hematologic type, or the also use the median CA 1.5 to as the patient characteristic.
And my second question is that I wonder why in Khon Kaen University have two kind of competitive uh, regimen with the same diagnostic patients, or do you have some different period that you practice the neck or PDS? Any comment on this clinical practice guideline?
Uh, in my hospital settings, we use the carboplatin regimens. And the worldwide, they also use the carboplatin regimens, so same, with or without the paclitaxel regimens.
No, I think so the judge mean that so why there's two groups or two type of treatments in the
Oh,
same group of patients though.
or the NACT and the PDS, right?
Yeah.
Oh,
So and how you classify, like when your patients come in, how
yes.
you gonna classify that? Oh, this one gonna get NAC or this one gonna get PDS.
So it depends on the clinical clinicians whether it's underwent the PDS or the neoadjuvant chemotherapy group. As I from my settings, this neoadjuvant chemotherapy groups also have tend to use in the more severity case because they are bigger or larger size in the tumor size. So we have to reduce or shrinkage the tumor size before go on the surgeries.
Okay, so that's explain your conclusion, right?
Yes.
So okay.